This video covers special tests for assessing shoulder instability, impingement, and labral tears. We will explore key examination techniques used to diagnose various shoulder conditions. Anterior shoulder instability is evaluated using several clinical tests. These include the load and shift test, apprehension, crank test, Rockwood test, row test, prone anterior instability test, Andrews test, anterior draw test, Protzmann test, Lefferts test, and Dugas's test. The load and shift test assesses anterior and posterior translation of the humeral head. The patient sits with the arm relaxed. The examiner stabilizes the shoulder and gently pushes the humeral head anteriorly or posteriorly. Translation is graded as normal laxity, 0-25%, grade 1, 25-50%, grade 2, 50%, reduces, and grade 3, 50%, remain dislocated. In the supine position, the examiner places the arm in the scapular plane, abducted 45-4 to 60-4, and applies an axial load. The humeral head is shifted anteriorly and anteroinferiorly. The degree of lateral rotation required to reduce translation is compared between shoulders to assess capsular laxity. The apprehension or crank test is used for anterior dislocation. The examiner abducts the arm to 90-4 and slowly laterally rotates the shoulder, applying an anterior force. Increased apprehension or pain indicates instability. Posterior pain suggests posterior internal impingement. If impingement is suspected, the relocation test is performed at 110-4 and 120-4 abduction. A positive test is when the patient appears apprehensive or resists further motion. The Fowler sign or Jobe relocation test helps confirm anterior instability. The Rockwood test involves lateral rotation of the shoulder at different abduction angles, 45-4, 90-4, and 120-4. Marked apprehension and posterior pain at 90-4 indicate a positive test. Less apprehension is seen at 45-4 and 120-4, and rarely at 0-4. In the row test, the patient lies supine with the hand behind the head. The examiner places a clenched fist against the posterior humeral head and pushes up while slightly extending the arm. Apprehension or pain indicates a positive test. A clunk or grinding sound may suggest a torn anterior labrum. The prone anterior instability test is performed with the patient prone, arm abducted, and laterally rotated to 90-4. The examiner stabilizes the elbow and pushes the humeral head forward. Reproduction of symptoms indicates a positive test. In Andrews' test, the patient is supine with the shoulder abducted to 130-4 and laterally rotated to 90-4. The examiner stabilizes the elbow and distal humerus, then lifts the humeral head forward. Symptom reproduction indicates a positive test. The anterior draw test is performed with the patient supine. The examiner stabilizes the scapula and draws the humerus forward. The amount of anterior translation indicates the degree of instability. The Protzmann test is done with the patient sitting, arm abducted to 90-4, and the examiner palpates the humeral head while moving it anteriorly and posteriorly. Pain or abnormal movement indicates instability. The Lefferts test involves palpating the anterior humeral head while abducting and laterally rotating the arm. Forward movement of the humeral head indicates a positive test. Dugas's test is used when an unreduced anterior shoulder dislocation is suspected. The patient is asked to place the hand on the opposite shoulder and lower the elbow to the chest. Inability to do so, with pain, indicates anterior dislocation. Posterior shoulder instability is assessed using the load and shift test, posterior apprehension or stress test, Norwood stress test, push-pull test, posterior draw test, Miniaki test, jerk test, and circumduction test. The posterior apprehension test is performed with the shoulder elevated to 90-4 and a posterior force applied. Apprehension indicates instability. The Norwood stress test involves horizontal adduction and feeling the humeral head slide posteriorly, indicating posterior instability. The push-pull test involves abducting and flexing the arm, then pulling up at the wrist while pushing down on the humerus. Posterior translation or apprehension is a positive sign. The posterior draw test assesses posterior instability by rotating and flexing the arm while pushing the humeral head posteriorly. The Miniaki test checks for posterior subluxation by flexing, adducting, and medially rotating the arm, then abducting and laterally rotating it. A clunk indicates reduction. The jerk test involves axial loading and horizontal adduction, with a sudden jerk indicating subluxation. The circumduction test involves moving the arm in a circular motion to detect posterior subluxation. Inferior and multidirectional shoulder instability are assessed using the sulcus sign, Fegan test, and Roe test. The sulcus sign is graded based on the distance between the acromion and humeral head. The Fegan test checks for apprehension with downward force. The Roe test evaluates instability in multiple directions. Shoulder impingement is evaluated with the Neer impingement test, Hawkins-Kennedy test, coracoid impingement sign, Yocum test, impingement test, reverse impingement sign, posterior internal impingement test, and internal rotation resistance strength test, IRRST. The Neer test involves passive elevation and medial rotation of the arm. Pain indicates supraspinatus or biceps tendon overuse. The Hawkins-Kennedy test flexes the arm to 90-4 and forcibly medially rotates it. Pain suggests supraspinatus tendinosis. The coracoid impingement sign is a variation of the Hawkins-Kennedy test with horizontal adduction. The Yocum test modifies the coracoid test by placing the hand on the opposite shoulder and elevating the elbow. The impingement test involves abduction and full lateral rotation, with symptoms indicating lesion severity. The reverse impingement sign is used if the patient has a painful arc or pain on lateral rotation. The examiner depresses the humeral head during abduction or rotation. Pain relief indicates mechanical impingement. The posterior internal impingement test is performed with the shoulder abducted and maximally laterally rotated, eliciting posterior shoulder pain. The IRRST is performed with the arm abducted and laterally rotated. The examiner applies resistance to lateral and then medial rotation. Good strength in lateral but not medial rotation indicates internal impingement. More weakness in lateral rotation suggests external anterior impingement. Labral tears are assessed using the Clunk test, Anterior slide test, active compression test, O'Brien, Kim test, biceps tension test, biceps load test, slap prehension test, Labral crank test, and pain provocation test. The Clunk test is performed supine, with abduction and rotation of the arm. A clunk or grinding sound indicates a labral tear. The anterior slide test is done sitting, applying an anterior superior force at the elbow. Pain or a pop suggests a tear. The active compression test, O'Brien, involves forward flexion and adduction with resistance, with pain in the first position and relief in the second indicating a superior labral injury. The Kim test applies axial compression and diagonal elevation of the arm, with a sudden onset of posterior pain and click indicating a posterior labral tear. The biceps tension test detects slap lesions by abducting and laterally rotating the arm and applying an adduction force. The biceps load test checks the integrity of the superior labrum by resisting elbow flexion during apprehension. The slap prehension test involves horizontal adduction with the forearm pronated and then supinated. Pain in pronation but not supination indicates a positive test. The Labral crank test applies axial load and rotation at 160-4, elevation with pain or clicking suggesting a tear. The pain provocation test rotates the arm in pronation and supination, with pain in pronation indicating a positive result.